Great. Good morning. Welcome to today's Leadership Huddle, hosted by Nick. And this morning's title for our session is The Skilled Nursing Sector, Where Do We Stand? My name is Beth Mace. I'm Nick's Chief Economist. And I'm going to initially provide you with some instructions related to the webinar's technology logistics. And then I'll be moderating your incoming questions for our Q&A at the end of our session today. So you have joined the webinar using either your computer's speaker system or your telephone based on your audio access during your most recent GoToWebinar session. You can adjust your audio access to this morning's webinar through either your computer speakers or your telephone using the settings in the audio panel, which is located at the top of your control panel on the right-hand side of your computer screen. We welcome your questions for our panelists during today's webinar. To submit a question, type your question into the questions panel, also located within the same control panel on the right side of your computer screen. You may submit questions at any time during the webinar, and I will then select certain questions and provide them to the panelists during our Q&A session. For those questions that aren't answered, we'll try to follow up afterwards with you. For those of you who are on Twitter, our hashtag for today's webinar is #NickLeadershipHuddle. Now, before I pass the mic over to my colleague, Bill Kaufman, who's a senior principal in our outreach team here at NIC, he'll be moderating today's session. I wanted to briefly share with you some of the results from our most recent Wave 9 Executive Survey Insights. Next slide, Nikki. As this chart shows, the largest share of survey respondents reported occupancy improvement across all care segments since the survey began. This is evident by the blue portion of the stacked bar chart, with anywhere between 22% and 42% of survey respondents reporting an increase in occupancy in Wave 9. You can compare that to the prior waves, 6, 7, 8, and earlier ones as well. Roughly 80% of the organizations with memory care units and 70% of the organizations with independent living units, 60% of those with nursing care beds, and roughly 45% with assisted living units reported an increase or no change in occupancy from 1 month ago. And this is quite remarkable compared to the patterns that we've seen in the past. So this data suggests that there's been a turning point a little bit in terms of occupancy. For nursing care on the right at 42%, that's the highest share of any of the care segments. And that increase might reflect the fact that we have seen a resumption in some elective surgeries in certain geographies across the US. On the next slide, you'll be able to find more insights from the survey related to both move-ins and move-outs, access to PPE and other equipment, and other reasons for the shifts that we're seeing in these patterns in occupancy in our detailed survey results, which you can find here on nic.org, NIC COVID-19 Resource Center, or more easily just by going to www.nic.org. And with that, I'll pass it over to you, Bill, for introductions and the agenda. Next slide, Nikki.
Fantastic. Thank you, Beth. Thank you all for joining our Leadership Huddle today, and excited to have Ray and BJ here with some insightful dialogue as we discuss the current skilled nursing business. We started these webinars in the middle of March, continue to hold them as there's tremendous need to share information in these unprecedented times of COVID-19 pandemic. And of course, the challenges within seniors housing and care properties are still evident, especially as it relates to testing and tracing. NIC continues to support all efforts associated with the adequate provision of PPE, testing, and tracing for the safe operations of seniors housing and care properties. In addition, in continuation with the NIC mission, NIC encourages transparency and understanding the virus. Given the vital importance of data availability, NIC is engaged in numerous initiatives to collect, analyze, and distribute COVID-19 relevant data on seniors housing and care. We're truly grateful to the many operators who continue to provide their data, even during this time of stress. These data contributors are improving transparency, which leads to credibility and ultimately trust by educating not just investors and operators, but also policymakers and general public. With that in mind, let us jump right into today's discussion. We are going to talk, after some introductions, we're going to give some historical context here, and then we're going to jump into what really happened, where do we go from here, and certainly some responses that that BJ and Ray and the companies embarked on during this pandemic. And with that, BJ, could you take a brief introduction for yourself and Genesis, and then Ray can do the same, and then we can jump in.
Sure, I'd be happy to. Thanks so much, Bill, and thanks for the opportunity to address everyone today. I'm BJ Oswald. I'm the Senior Vice President of Strategic Development here at Genesis Healthcare. I joined the company 22 years ago, was its banker before I joined the company, originally joined on the finance side as the treasurer and then moved into a strategic development role, I'd say in the early 2000s. So I've been doing this particular job for quite some time, focusing really more recently, I would say pre-pandemic, on value-based care delivery models, and we're anxious to get back to that as well. So, and I've worked with Ray, so I'll hand it over to Ray.
And I will unmute. I already forgot rule number one, unmute. Hi, everybody. I'm Ray Tidiers, and I too am very thankful to be here to talk about this topic. Obviously, we've heard a lot in the news recently about COVID-19 and nursing homes, and a lot of it has not necessarily been productive conversations. So anytime I have the opportunity to participate in a dialogue that starts to shift the conversation a bit, I'm very excited to do that. I'm currently the Executive Vice President and Chief Strategy Officer with Sava Senior Care. As BJ alluded, prior to that, I was with Genesis for quite a long time. I've been involved with a lot of the larger nursing home chains in the company over the years, and have been in the business about 30 years at this point. I've been in operations and in sales and marketing, and at this current juncture in strategic operations, really, I am involved with portfolio management, sales and marketing, new development, program development, those kinds of things. So obviously have been extremely impacted by COVID-19 since that basically turned our world on its ear.
Okay, well, thank you. And BJ, if we could just start with you, certainly we have a lot to jump into today. And as we were kind of joking, we could probably be here for about 8 hours a day if we wanted to. If, you know, from the context of the pandemic, could you give us some historical context and tell us really what happened here in the last few months regarding the pandemic with skilled nursing properties?
Sure. And 4 months seems like 4 years for us. So, you know, I'll try to do the best I can. You know, before we start, the one thing I really want to acknowledge, so I'll have a little bit of a soapbox here if you'll allow me, the enormous courage, compassion, and resilience of the American nursing home workers. Now we're seeing a lot of folks, to Ray's point, there's a lot of blame now going around. But I want to remind everyone that no nursing home in this country had ever operated under pandemic conditions. And we're all still learning. We've had to adapt very quickly. We've had to be nimble. We've developed guidance, basically, you know, building the plane as we're flying. And those staff that showed up again and again to care for the frail and vulnerable patients that we have, when we knew so little about the virus, we had so few resources available to them. Nobody was cheering them on at 7 o'clock every night, and they continued to come, and we owe them an enormous amount of gratitude and respect. So I wanted to start there. With respect to what happened in nursing homes, since everyone really wants to say, you know, what happened in nursing homes. Nursing homes are especially hard hit because they serve the oldest and frailest, with folks with multiple chronic conditions. We need to remind ourselves that over 50% of the folks in our settings are cognitively impaired, and that makes it particularly difficult for staff to maintain room restrictions and other infection prevention practices, such as masking and frequent hand hygiene. Nursing home residents live very close to one another, and multiples in a room, and transmission and increasing the risk of transmission, and especially as we're learning more about airborne transmission. I'll also say that absent any adequate testing to identify contagious individuals, asymptomatic transmission allowed the virus to spread silently. I think we all now know that to be true. Swabs and viral media and the capacity to test were woefully inadequate in March and April when the virus was all around us. Nursing home PCR tests were not prioritized by labs, and the turnaround time to get results back is still, even now, often 3 to 5 days, which renders negative results of those tests meaningless for us, and asymptomatic individuals with positive tests are inappropriately cohorted. So when the virus first was confirmed in our setting on March 16th, in New England. At the same time, now we know that it was likely throughout the Northeast. So the first states that were broadly impacted, we did have a first large incidence in Vermont, but Massachusetts, New Jersey, Connecticut were early states. Given our geography, predominantly in the Northeast regions that were hard hit, this hit us like a tidal wave before we ever, really realized what was happening. It proceeded down the coast into Pennsylvania, Delaware, Maryland, and has continued to proceed down the coast. Now we have facilities in Florida, also in the Southwest, New Mexico, Arizona, that are being impacted. We're down to now about 700 active cases in about 10% of our facilities. But given that geographic concentration, we've had 8,000 residents, roughly 20% of our overall population confirmed or presumed to have had contracted COVID across about 60% of our portfolio. And the unfortunate part of all of this, of course, is the high fatality rate in our setting. The most devastating impact of this is roughly a 20% fatality rate due to the age and fragility of the population. So we can talk about what we learned. This is not a bad apple problem. There are people who, there are facilities that don't always practice the appropriate infection control practices, and we can use our surveys and regulations to identify those and improve upon those, but that ultimately won't stop the spread of COVID. We provided our data to Harvard and Brown, who have helped us get a little bit more background with respect to what characteristics were most likely to have caused higher outbreaks in our centers. And it really comes down to community prevalence and the size of the facility itself. So I think actually the former CDC head said it, Tom Frieden said it yesterday with respect to school openings. The things that we can do to open schools safely are not necessarily things that we're going to be doing inside schools themselves. It will be the reduction of the community transmission, since that's really what led the most and continues to be the highest indicator of whether or not we're going to see COVID inside our facilities.
Ray, can you also expand on that? Anything to add, and also really the responses that you and Sala had to the whole pandemic situation thus far?
Yeah, I think most of my comments align directly with what BJ just said. I can add a little bit more color in some areas. Going back to the beginning, I think one of the greatest handicaps that the society had, but most importantly in our sector, was the great unknown. We had a silent enemy invading our centers. And in fact, as BJ alluded, probably way before we even knew it. Hindsight now tells us that we were probably in communities that had a significant prevalence of the infection. We're probably having our workers bring infection into our buildings. And that continued even after we established policies and procedures around screening of our staff when they entered the building or any visitors to the building, because of the prevalence of the asymptomatic cases that we just simply had no idea existed at the beginning of the pandemic. And so I think that, our experience began in March, although we had begun planning for something. We saw something coming. We just didn't know what to plan for. And we really had no idea what we were going to do to prevent the spread. What we thought we were going to do was prevent it from entering our buildings at all. We thought we were going to be able to lock down and keep our current residents safe. We acknowledge that there's sort of two missions that any nursing home serves in their community, right? The first is protect the patients who live with us, take care of the patients who live with us. And the second is serve our role in the continuum well, take patients out of the hospital when it's time so that those beds in the hospital become available to other acutely ill people. And what this did for us really caused a sort of a quagmire in that reality, that we've got these two responsibilities, and we erred on the side of caring for the residents in our buildings. and we locked down, and we instituted very strict admissions procedures. We required tests, even though they weren't available, which basically meant we weren't getting many admissions. And we implemented pretty stringent PPE requirements even before we had guidance as to what PPE to use, what would work. Of course, what we realized is we were nowhere near stocked for that level of PPE consumption. And even when we wanted to go get more, those supplies were not necessarily available. So in the early days, our naivete about the virus, as well as our sort of, I think, shared misperceptions around how this thing was going to spread, did make us, as the nursing home environment, sort of a petri dish for a combination of, all the things that are known to cause or contribute to the spread of the virus: close proximity, inability to social distance, protection from each other, and as well as people coming and going from our centers. And even with our safest precautions, we ended up in the early days saw the prevalence of the impact of the virus. I think that actually contributes to some of the data we saw in the beginning, because the learning has occurred and the sector has responded. And I think we've gotten a lot smarter about how to protect our residents and a lot smarter about how to help the hospitals by taking admissions. We know now how to segregate patients, how to cohort patients. And so that is helping us see a recovery in our census across the sector. But we also know that the initial impact of the virus on our business is going to sustain itself for quite some time. It's going to take a long time for us to recover. Just to put it in context for you, we have 170 centers roughly across the country. We now have, as we stand as of yesterday, we've seen infections in 125 buildings. That doesn't mean we have 125 active infections at this time, but 125 of our centers have been impacted them since the start of this pandemic. We've had 2,516 of our nearly 10,000 residents impacted by the virus. They COVID positive tests on those residents. We've also had, in addition to that, 1,000 employees be impacted. And that at times has been the greater of the two challenges. Caring for our residents is something we do, and we have backup systems in place, and we have the ability to staff our centers under contingencies, right? We're used to dealing with that. But what we're not used to is when the impact of the virus hits our staff and our staff can no longer work. That was really devastating to a number of our facilities. We've had, unfortunately, about a 20% mortality rate, but we've also seen about 1,500 of those 2,500 folks recover and come back to live in our centers again. That's a story that the media and the folks who are paying attention right now are not understanding. Is that, yes, this virus is really terrible for our frail elderly, but the majority of them are recovering and coming back to our centers to live again. And that's a part of the story that I feel is something we got to hang our hats on relative to our own retrospective on what went wrong and what went right. But also it's part of what we got to understand around what was the difference? What was the catalyst behind why somebody survived the infection and somebody didn't? And what we're learning about that, quite honestly, is that there's not very much difference between a nursing home resident and a resident in the community, or an adult in the community. The virus manifests itself differently in different people. And there are different symptomologies that go along with it. And some folks frail elderly are testing positive and being asymptomatic. Other frail elderly are testing positive and being devastated. And so the reality is that the diagnosis itself, the test itself, is not going to help us determine what we need to do about it. All it does is tell us that we've got to treat that patient separately from the rest of the population. And so what happened with us was, we went through basically 4 phases, and I believe there's going to be a 5th. But the first phase was, oh my God, there's a virus out there, right? And it's really bad for frail elderly people. What do we do about that? This is all we know, right? And so the phase 1 was, how do we protect our frail elderly living with us? What do we do? And that was lockdown, keep the residents safe, and stop visitation, do what we can, implement systems for people coming and going. Phase 2 was, okay, we've got virus in our building. Now what do we do? How do we handle that? Do we ship them out to a building and cohort all of our positive patients in one center? Or do we create, separate environments for them in the building? How do we handle it? So phase 2 was getting adjusted to the idea that operationally, we got to deal with this virus in our centers. Phase 3 was, okay, we figured out a little bit about what works here to take care of a COVID patient while at the same time preventing the spread of the virus to those who are testing negative. How do we do that? How do we do that in such a way that we can live up to our obligation to assist our hospitals, perhaps by taking other COVID patients? And so we've begun to think about in phase 3, how do we step back up again in terms of serving our role in the continuum? And phase 4 now is, okay, now what? There was a hope that we were going to prevent the virus from spreading into other buildings. I think many of us are of the volition that if you haven't had the infection in your building yet, you're lucky. And you're probably going to need to face the fact that it's going to happen at some point. And so phase 4 really is, what does this new reality look like? Everything from sales and marketing and relationship development in the hospitals when you're not allowed in the hospitals anymore, to admission screening and protocols for ensuring that you identify risk of patients being admitted at the right time and having the right environments for them. So all of those things are currently being revisited in this phase 4.
Thank you, Ray. And BJ, so Ray, you're really bringing us along to the next topic as far as, the now what and what happens during the pandemic right now and after the pandemic. And BJ, if you could kind of continue on that and talk about the position within the continuum. How does the industry recover, and what adjustments that you all are making and opportunities, right? Because there's not a lot of discussion about opportunities. Are there opportunities like telehealth, et cetera? If you can hit on some of that, that would be great.
Sure, that's great. Yeah, and before we can really talk about what's next and where do we go from here, we do have to, I want to sort of touch upon a few points that Ray made with respect to testing and PPE, because in some ways we've come a long way, and in some ways we have not come a long way, and we still have a long way to go. So we talked a little bit about testing and cohorting. We can't do cohorting effectively without testing, and we didn't have adequate testing in the beginning. In April and May, I would say in May and into June, we started to be able to access more tests. But I will still say that testing really needs to be rapid testing. It needs really to be able to be something you can turn around in about a day, not 3 to 5 days. It needs to be inexpensive. Today it's $70 to $100, and we need much, much cheaper testing. And it needs to be reliable. There are some rapid tests out there, but they're not, the reliability of them is actually causing more problems, probably than helping. So testing needs to continue to be developed and be to that level before it's really effective for us. We welcome the states who are now beginning to implement mandatory testing. We've often, for a long time, we've recognized that testing probably on a weekly basis, and certainly on a weekly basis, at least in the most heavily hit markets, was necessary. Unfortunately, what's happening now, I'll say two things about that. There's not enough testing capacity for every nursing home and every resident, both resident and staff, to test on a weekly basis in the United States today. The labs don't have the capacity to do that. There's not testing supplies to enable us to do that. And the cost, it still remains. Who's going to bear the cost of this? It will be prohibitive to some extent if we don't develop a nationwide strategy. And we continue to hear stories coming out of the most recently hit markets that there still are. They're missing reagents, they're missing supplies. So the testing shortages throughout this was, we fixed one piece, we got the tubes, but then we didn't have the supplies or the reagents. So this is, this really needs to be resolved, and it needs to be resolved soon because it's something that needs to go into effect now. I'll also say that this is part of in the implementation of resolution and trying to get into the next phase of this, trying to come together with strategies so that there's not 50 different ways of doing things across the 50 United States. Right now, with everything from testing to PPE to cohorting to resuming visitation, every state has their own flavor, and it's becoming very difficult to work within that kind of an environment. Not only for a company as large as Genesis in the 25 states where we operate, but really, I mean, it affects everyone. I just was on a call this morning where there was talk about quarantine restrictions now amongst, between states that may apply to healthcare workers and requiring them to quarantine when they return back from visiting a hotspot, which may be far away and it might be the state next to you. So, this will continue to be something, all of these different regulations by state, particularly those related to testing, are going to impact us a lot. I'll also say a word about PPE. In the beginning, I think everyone is well aware, one of the things that really, I'll say if anything went wrong, our having to go to crisis mode on PPE was harrowing. We knew it was dangerous when we read CDC guidance that we needed to reuse masks. People were putting them in paper bags and then pulling them out for up to a week. We were, I'll say we were grateful when we got past the crisis level of PPE. Having said that, I don't think we're completely out of the woods on PPE either. Today, we've continued to have problems throughout with gown usage, with the availability of gowns, for instance. We've moved through a number of different alternatives for gowns, and we're now on reusable gowns. But the other thing that's happening in the PPE market is price gouging. So there's, rapid increases in the cost of PPE as well. So even as we speak, if it's not gowns, it's gloves. So, there are constant shortfalls in the supply chain and the availability, generally speaking, in from market to market of the PPE we need. So before we can even get to opportunities, we have to get past some of these issues so that we can, move ahead to the opportunities. And I don't know, Ray, if you'd add anything to that. The latest I heard was gloves.
No, I think you said that well, BJ. The reality is that there are still some major obstacles to us moving forward in the way we know how we need to move forward. The one thing that I would add to the commentary that BJ just made was there's another aspect of this that is just beginning now, and that's that retrospective look at what happened and what we're going to do going forward. There are a number of parties interested in that, for everybody from state and local health departments to CMS, and as well as the sector itself. And I do think that having there be some consistency and some expectation around protocols for what actually does constitute a safe admission, what are the requirements for PPE in terms of expectations for having on hand and other things like that, and as well as for the sourcing of those things, because right now there is still a challenge where even though nursing homes have proven that they are the most vulnerable to the scar of the pandemic, we're also not prioritized. So tests are not necessarily disproportionately being given to those who need them the most. And so I think that there is some responsibility on the part of the sector to rally and to bring these facts to the attention of the policymakers, because as BJ said, I think the road forward is we've got a map. We sort of understand what needs to happen to go forward. But to do that is going to require some concerted effort on the part of not just the operating sector, but also those who help control and influence the environment in which we operate. And coming together on those things is I think one of the biggest challenges we're going to have, because it's going to require us to communicate across competitor lines, to have our associations take on policy at its core, and to really speak up against those who are providing, quite honestly, in my opinion, negative information out there about the reality of what we're up against. It's easy to sit back and point at things that went wrong. It's a lot more difficult to point out why they went wrong. And to do that is going to require us as a society to look at some of the things that happened in this period of time happened because we were set up to perfectly to experience what we experienced. And if we don't want to experience it again, we got to work on the way we're set up.
Yeah, and so I'll just, to build on that comment a little bit, one of the things that we've, I think everyone's starting to do, we built established admission quarantine units in every one of our centers. Most states are kind of mandating that, I think, at this point in time. These are discrete units. They can, usually about half of a monthly admission volume in every facility to quarantine, to quarantine folks, because we're still not getting necessarily every admission is not necessarily tested at the hospital immediately prior. And remember, it needs to be immediately prior, not 3 or 4 days or prior to admission. So we now have admission quarantine units established in all of our centers. We're testing immediately after people arrive, and then testing again to move off of the admission quarantine unit. And I'll say the importance of this, along with the things we've already talked about, is we are getting now comfortable. Our interprofessional teams are meeting on a regular basis, and in many cases determining that there is an ability to safely admit. I will say all of our centers experienced an admission hold period following any positive test, whether it was a resident, a staff member, or a provider who had been working in that facility. So all of the 220 facilities had an admission hold period, and some of them for quite an extensive period of time. And we'll get into the implications of that for occupancy. But the admission quarantine units now, and now that we have, we've learned what we've learned, and we are in a better place with PPE. A number of our centers are comfortable reopening for admissions, even while there are still some active cases in our centers, provided that they can assure that those are safe admissions. And the reason this is important is to move forward, we're going to have to keep our facilities open. One of the other things I wanted to mention that we did, in addition, Ray, we did have that come to Jesus where we thought about what do we need to do? How do we weigh our responsibility for our existing residents with our responsibility for our community? And in our markets where the fear of the surge usurping the capacity for hospitals was so intense, we decided very early on to establish a COVID specialty center. We opened one after a lot. I will say it was a great deal of preparation to get these facilities open. We opened our first one in Piscataway in North Jersey on April 8th, which was very early. We followed that with facilities in Philadelphia, in South Jersey, in throughout the state of Maryland, Baltimore, Anne Arundel, and Frederick counties, in Albuquerque, in Denver, in Hartford, and Springfield. So today we have 12 facilities. We've pared those back based on the continuing need for COVID positive beds in the marketplace. So initially they started as whole facilities, and now they moved to a single floor, and now they're back to a unit, and they're remaining full as for COVID positive patients. But it's also gave us the ability to cohort patients safely across our facilities, which was great, and to open that opportunity up for the expanded community as well. So we were able to take COVID positive patients from other seniors housing operators, not just skilled facilities in the community. And then once patients recovered, return them back to their original setting. So I'll say that both of those things have been important strategically for us. Having said that, occupancy has been affected. There's no question. Overall, our occupancy today is, across our whole portfolio, is about 75%. We were having, and Ray and I talked a little bit before this, we were having the best months ever. I will say, before COVID hit. In February, we were at 88%, and we were starting to see, to feel those tailwinds that we had been sort of hoping for and expecting for some time. That occupancy is very variable, so it really depends on the market. So, it's probably, for us, it's worst, of course, in New Jersey and Connecticut. You're in the high 60s, and in states like West Virginia, I knock on wood, they have been relatively unimpacted so far. They continue with occupancy near 90%. So it really depends a great deal upon the marketplace itself. And it was impacted by two things: those admission holds, as well as the fact that even in unaffected markets, our occupancy declined due to the fact that hospitals were essentially cleared out. So the hospitals are recovering, but they're recovering slowly. Most of those began accepting, began elective surgeries in April and into May, but it's slow to return. And our referrals are still about 80% of what they were pre-COVID, and our admissions about 50 to 60% of what they were pre-COVID.
And BJ, from that perspective, I mean, right now, of course, I don't know exactly where occupancy goes or not, but staying profitable at that level at 75%, is there discussions on how that works? Is it still profitable? How long is it sustainable, et cetera?
Well, we were fortunate so far to, we're very grateful and appreciative for the support that the industry has received from the federal government and from state governments, I'll also say. So we've received about $190 million in federal funds, including about $8 million from the sequestration suspension for this year, as well as about $30 million from state FMAP increases. In addition to that, we did access some of the loan programs. The Medicare Accelerated and Advanced Payment Program added about $160 million. Unfortunately, that is scheduled right now to begin repayment in August. We're hopeful, and we're having conversations about the potential deferment of that until next year, like it was for hospitals, and potentially even the opportunity for forgiveness if that, in alignment with what the SBA loans did. So we're hopeful for that. We're also in conversations about a STEM 4 package, and are hearing that conversations are continuing. Some folks are optimistic about that, and we are as well, because our expenses are higher. So not only is our top line impacted, but there's no question there are COVID-related expenses, whether you have a COVID specialty facility or not. Most of that is staffing. It's both, we have increased agency, of course, which we'll continue to try to, and we're winding that down, premium pay, which went into effect, immediately, and we'll wind that down. But there are some lingering effects of staffing inefficiencies, I'll say, around these smaller units. So now in a facility, you used to operate one facility, now you have essentially 3 facilities in one. You might have your COVID positive facility, dedicated staffing, your COVID negative with your dedicated staffing, and your AQU with dedicated staffing and PPE. So there are incremental expenses and inherent inefficiencies in the way we're operating today. So the answer is, in the long run, no. We need to get our occupancies back up. We're working hard on that. We've just done, I think, the first ever that I can recall, a second budget process. We just are winding that up, and new incentives, for our centers. But I will say those incentives are balanced, both on the grow with occupancy, but do it safely, and infection control practices. So we're putting as much weight on, on infection. We've had a 96% deficiency-free survey result for the infection prevention, the infection surveys so far, and we're hoping to continue that as well. So it'll be all hands on deck to get, our facilities back online. The good news is that, when you're in such a big hole, the first 5 to 10%, it comes back relatively easy. It's going to be that last 5% that's going to be a little bit more difficult.
And Ray, how about on your end with Sava, from occupancy, profitability, and also the government funds, the topic as well?
Yeah. Before I jump into that, there's just going back to the prior question. There are a couple of things that I think are takeaway learnings and innovations that are going to be a part of our success for the future. Adversity breeds innovation, and we certainly had to come up with ways for controlling the impact of some of the decisions we had to make in terms of restricting access to our residents and restricting access to our centers. Some of the changes that were implemented by regulators and by the government to help us in that process, I think, are things that provided an opportunity for us to demonstrate how things might be done better with or without a pandemic in the future. Telemedicine is a great example of that. Telemedicine is one of those things that's been around for a long time, and we've been trying to figure out how do we get this thing launched. And the reality is we figured out how to do it overnight when push came to shove, because even if you have to use a handheld device and you're on Zoom to talk to the doctor, you're engaging in telemedicine. And it was instrumental in helping us ensure that we had consistent practice and that we were taking care of the residents as best as possible while maintaining isolation and distance. It also, telecommunications have also served significantly in terms of helping to ease the pain of being separated from your loved ones in the nursing home. And we've had a lot of partners step up with some assistance in that regard, helping us access CMP money, specifically for purposes of acquiring mobile devices, iPads and other such devices that can be used specifically for communication between families and residents, and enhanced communication in a way that changes the meaning of the visit and really does make it more of an interaction with the staff as well as with the family. So we've seen some silver linings, if you will. I hate to call them that because it's really we don't really see much shine on the silver yet. But I will tell you that there's learnings out of that are going to stay with us, and they're going to be head scratchers as to why we didn't just jump in and do it sooner. The challenge with PPE for me is still really about the understanding of what actually it does for us, right? Because as we learn more about this virus, we're now learning that it might be, airborne, and which we heard for the first part of this pandemic that it wasn't. We were out there washing down surfaces, and now we find out that all the surfaces, really, that surface contamination is probably not really a big source of the problem. The air might be. None of the PPE that we're using is designed to prevent folks who are not interacting directly with a resident. And so, HEPA filters and all those other things, and redesigning and reengineering our space and our air systems and our, the concept of PPE or protective equipment in general has just gotten a lot bigger. Because in order to create a protected work environment, a protected place to live, you're now talking about infrastructure. And to power that infrastructure 24/7, you're now talking about a significant financial burden. Somebody's going to have to pay for it. And the reality is that margins in our business don't allow us to sock away the money to do that ourselves. So we're going to have to rethink the entirety of the equation around investment, what it means to invest in our properties, and what the expectations of an investment are. And so I expect that we're going to see a lot of takeaways in that regard as well. So jumping forward to the question you asked me, sorry, I had to pontificate a bit on that. But
yes, I second the motion. Absolutely. So,
yeah.
Absolutely right. I mean, we've neglected these facilities were built a long time ago. They weren't built for this. And now we have to rethink them, not only from a safety perspective in terms of HVAC systems, but also the configuration themselves. And there needs to be reinvestment in this space. And if not now, then when? So
that's right.
Sorry, didn't mean to jump in.
I mean, yeah, no, but it really resonated with me when we were seeing all these pictures on the news of family members who resorted to standing outside the windows to see their loved one. And I thought, we are a modern healthcare industry. We are, and yet the only way for us to provide safe visits for our families right now, because of the state of our environments, is to have folks wave at their loved one through the window. That's a wake-up call. That's got to be a wake-up call. And if the pandemic does that for us and for our sector and provides a realignment of some resources to help us get that done, then we'll all be better off for it. As it relates though to the impact on the business, it's clear. And Sava is not the size of Genesis, but our percentages are pretty much the same, quite honestly. We saw a 10% decrease in total occupancy. So we're down around the 14,100 range right now in total occupancy, 20% of which is what we call premium mix or non-Medicaid mix. And that's interesting because that's pretty much what it was before. Sava's got some buildings that are in a different footprint and in different markets than what Genesis has, but we always ran about 20% of our occupancy as non-Medicaid. Part of that is artificial, because another thing that evolved during the course of this pandemic in reaction was the waiver of the 3-day qualifying stay and our ability to skill residents without having to have to transfer outside of the center. And that allowed us to really not only pick up the pace in terms of our physician engagement through telemedicine, but then to also diagnose very early symptom changes and care changes and increases in that allowed us the resources to pay for
and be adequately paid for the services we're providing for our residents. So that waiver of the 3-day stay is something that I think did two things. Number one, it ensured that the patient was being properly compensated for the care they need. And the second is that it allowed us to keep that patient in our center with the added resources rather than the alternative of having to send the patient out. And that didn't work 100% because quite honestly, we were struggling with staffing and it wasn't always possible for us to provide that added extra layer of service. But where we were, we did save a hospital bed for somebody who was more acutely ill and might need it. And so those two things kind of taken together, I think, are manifesting themselves in what we're seeing here in our mix. Relative to the funding, the dollar amounts are very, very similar, and we received them from the very same sources. Some of that is stimulus money, some of it was money from the states in terms of add-ons to the Medicaid rate. Some of it was permanent. Some of it's been added permanently for buildings that have got COVID-19 residents in them. And some of it is we're expecting we're going to have to be held accountable for how we spend that money because it was gifted, in quotes, in a way that may very well be, pay us back. So we're tracking through accounting mechanisms very diligently all the expenses associated with COVID care, tracking everything related to our additional staffing requirements, our hero pay, everything we had to implement relative to getting through the crisis, with a full expectation that there's going to be an accounting day is coming. And so although we are in a place where we're very grateful for the added support financially to the sector through this time. If we had not had that, we wouldn't be having this webinar right now. At least these two characters wouldn't be your guests. So I can tell you that. We would not have had the cash flow. And I think there are many other operators out there who would echo that sentiment. At the same time, we know that that's not going to last forever. And so the reality is that we are looking at, and at the same time that we are tracking all of our expenses related to COVID and providing offsetting accounting to make sure that the dollars that we received are being adequately and properly, attributed to those expenses. We're also thinking about the future of our business model, because we know that if you strip away COVID, the good and the bad, the expenses and the the added financial incentives, you still got a situation where we're dealing with an impact to our long-term care base through this virus that's going to take us a long time to come back from. The sector was already trending down in long-term care. And the fact of the matter is this virus, this pandemic, has done two things. Number one, it has eroded our long-term care base. But number two, it has also made people much more fearful of the environment. And so it's always been that nursing homes were typically a placement of last resort. It wasn't a destination place for many folks. They made the decision out of need. And that need was always weighed against other options. This pandemic, I think, has created a mentality in the consumer and in the referral source, and in some cases, even our practicing physicians and others who are referring people to other locations with the explicit intention of avoiding the nursing home stay, because there's concern that people in nursing homes are going to be infected at a higher rate than people who are not in nursing homes. And so we've got a challenge on our hands here with that in terms of the perception in the market and also in terms of overcoming the reality of that. And so longer range, those incentives are providing us an opportunity to get through the day and get through this period, but they're also forcing us to rethink our business model and to rethink what it looks like. How are we going to operate these centers at a lower occupancy and still sustain the level of service we've always wanted to and need to provide to our residents?
And let me just add one additional point there too, and to try to do more inside our facilities. So along the lines of reducing readmissions to hospitals, and I'll say all discharges to hospitals. And one of the things that we also operate is a long-term care ACO. We have a large physician services organization. So we were fortunate to be able to have that organization. And we also use telemedicine during the period of COVID. I would say that's up about 15%. And we were fortunate to have hundreds of physicians and nurse practitioners that are also participate in our ACO. So the ACO was a bit of a beneficiary of the reduction of, all managed care companies, the reduction of admissions to the hospital from the long-term care setting. But we really have only scratched the surface there. I mean, there's a lot more that we can do. to provide more services in our space. We've always, there's always been mobile diagnostics, but we can certainly build upon that. Can we be doing more urgent care inside of our centers? Can we bring more dialysis into our centers so people don't have to leave our centers? Can we expand upon the telehealth component to bring specialist care, to expand upon specialist care inside our facilities? So there's a lot that we can do along those lines, and even just the surveillance that we've implemented, the screening that we're doing 3 times a day for every patient who's in our centers has had a positive impact on infection control practices. We expect that to, in and of itself, to continue to provide some overarching benefits going forward. So I think coming out of this, there are some silver linings. I think the partnerships that we've formed, it's caused us to communicate with each other internally a lot more. We're on the phone all the time with each other internally, but also with our state partners and our hospitals. The lines of communication are now open. I do see this as a real opportunity for us to forge those partnerships into something more meaningful long term.
Fantastic. Yeah, go ahead. Go ahead, Ray.
No, I just want to comment on one thing on that, that sometimes the other interesting thing about the human dynamic is that sometimes crisis brings out the best in people, and sometimes crisis brings out the best in organizations. And we have seen examples, not everywhere, but we've seen examples of real partnership come out along the continuum with our regulators, as well as with the local departments of health, with our first responders, in certain areas that have really, set an example for how, a real continuum should work. We've used the word continuum since I've been in the business for 30 years. The reality is, we've operated as separate stops along the way. The idea of coordination along a continuum, I think I can point to several examples where it was demonstrated in our response to this crisis. The question is, how do we make that sustainable outside of a crisis environment? And that's the real opportunity, but I also feel, perhaps this is the Pollyanna in me a little bit. I feel that there's an appetite for that level of dialogue at this point in agencies and in organizations and in private and not-for-profit, as well as in for-profit sectors. So I feel like there's an opportunity to remain optimistic and to be clear and sure that we may not know exactly what our sector is going to look like going forward, but we know it's going to be here. And there may be, even on the other side of this thing, more business opportunity in our sector. Because, as BJ pointed out, we learned some things. If we have dialysis dens in our centers, many of the infections that came into our building could have been prevented. If we had more integration of physician services and support services, ancillary services, as we call them, in our centers, and there was a connection to the biology of the building, that would have been better. It would have been better for the treatment of our residents, and it would have been better for our centers. And so all of those things taken together, I think, are creating some hints for us as we look to explore about our new business opportunities going forward.
Great, thank you. And before I hand it off back to Beth, let me just say thank you very much, BJ, Ray, for your time. I know you both are very busy. From NIC, thank you for your time. This has been fantastic. It's been a pleasure. And with that, I will turn it over to Beth. Thank you.
Great. Well, we did have one comment from our audience wanting to give you guys kudos for shouting out to the staff and to all the people that are on the front line, and to yourselves and your organizations for being able to rise to the occasion and do as great as you've done. So thank you to all of you, including every layer of the staff within your organizations. So,
thank you.
And then we had a couple questions about occupancies, but you both did that pretty well, so we don't need to do that. I did have one question from someone asking about, the flu. Before COVID, flu was a big topic, of course, right? So now there have been heightened safety measures and all the protocols that you've put in place. Is there any way to tell if the residents that would have succumbed to flu didn't because you had so many additional measures in place to prevent COVID, or is there no way to make that distinction?
No, I've never been asked that question, but I'm going to take it back because I think that there's, there really is something there in the context of the question. Because what you're basically asking is about our infection control procedures, right? Did we implement something bigger, better infection control awareness that might have had subsequent benefits to other things that might have been spread? And you know, I think that's a logical question. It's also a logical thing to explore and to look at statistics related to infection rates in the community versus our nursing facilities with the flu. So I'm certainly going to take that back to our quality assurance people. I think that's a great question.
Yeah, and I've been thinking the same things. I mean, you know, as we've been thinking about sepsis, for instance, and prevention there, and the vigilance that's required to do that. I've been wondering about the potential implications for reducing all readmissions related to infections. Interestingly, with respect to the flu, as this hit, we were coming out of the flu season.
I know.
So we're about ready to enter the flu season, right? So for, you know, the 2020/2021. So maybe that's a better question asked next spring. I mean, you know, I think everyone's heard that this is going to be incredibly complicated now that those symptoms present. And again, back to testing. If we have adequate testing, we'll be able to sort of, you know, sort this out. You know, I am hopeful that this will have, you know, that vigilance will have positive implications, but we won't really know until we get through the next flu season.
Okay, I have another question. Have you seen pent-up demand from deferred elective surgeries that maybe could benefit the occupancies? Has that happened yet? I know, BJ, you talked a little bit about the sort of hospitals coming back and doing some elective surgeries. Has that started to boost the occupancies, do you think, in your property?
I would say there was a little bit of pent-up demand for, you know, so what's been very difficult for hospitals is knowing who was open and who wasn't. Who could take a COVID positive patient and who could take a COVID presumed negative patient. So just getting that level of assurance in the marketplaces. And as we go into our second wave, I think the IHME, you know, we're looking at a potential upsurge in our markets again in sort of September, October timeframe. So, you know, getting that certainty out in terms of who's available, you know, who's open and who's not open is probably the most important thing for us. Specifically, your question again was around
the pent-up demand from deferred elective surgeries.
So here's the thing that I think there's pent-up demand for: chronic illness. So we do know that heart failure didn't go away during COVID, but heart failure treatment went away during COVID. So one of the things I am concerned about, and I think all physicians and the medical community at large are concerned about, is what's been happening in that time frame while people have been avoiding the ED and avoiding healthcare at large, even avoiding physicians altogether. So I do believe that I think Ray made this point earlier. The folks choose skilled nursing facilities for reasons that they, you know, at that point in their lives where either cognitive deficits, chronic illness, or other things prevent them from really, you know, continuing to live at home or live in any other setting. And I expect that will continue to be the case. So I do expect that there are people out there with heart failure, with other chronic conditions that do need treatment. Do skilled nursing facilities serve as a great as a location for us to be able to relieve that, especially if the hospitals continue to not only want to, but need to maintain some extra capacity for the next wave and beyond. Absolutely.
So I have a few more questions, but I want to be mindful of the time. So I might send you guys these questions and we can collectively respond to the folks that have submitted them. So Nikki, if you could go back to the slide deck for a second. I just wanted to mention a few things. One is that Nick continues to work on what we call our skilled nursing data initiative, where we collect information at the property level to give us a sense of what's happening in skilled nursing properties. If you're a skilled nursing operator and you don't contribute, we would highly encourage you to try to start contributing, and you can contact Bill or myself, and there's an information on here on where you can get it if you have a copy of your slides. And the next slide, I wanted to mention that our popular Nick Fall Conference is coming up. It's going to be over the course of 2 weeks. It starts October 6th through 8th, and then the following week will be October 13th to 15th. The first week is going to be educational sessions, including our Nick Talks, which are very popular. Mark your calendars for this. The second week will be more an opportunity to do connections and networking. And we're really excited. We've worked really hard on trying to come up with the right programming for this. So mark your calendars, and I think you won't be disappointed with that. You'll also, after we're done with this webinar, you'll get a chance to respond to some questions about what you thought about the webinar. We appreciate any feedback you have on it to help us go forward. And next slide, please.
So Beth, I'll say that it'll be the first Nick Fall conference that's business casual. So.
very, very business casual, at least casual from the bottom down, right?
Exactly. 50% business casual.
Yeah, so on behalf of Nick and Bill Coffin and myself, I'd like to really thank you, our panelists, BJ and Ray, for joining us. And thank you everyone who's called in and dialed in. And as I said, if you submitted questions, we'll try to respond to those. Thank you for having joined us. And this concludes today's webinar. Thank you.
Thank you.
Thanks, everybody.
Thank
Bye-bye.
you.